Good evening, everybody, and thank you, and welcome to this inaugural session of the CMEs from the West Bengal State Branch of the Indian Society of Anesthesiology. So let me make it simple as to what we will possibly go through over the, I don't know how long it will take. That is, we will, the workstation has a functional anatomy which includes the gas supply, the vaporizers, circuits, ventilators, scavenging system. But because I know that we will be dealing with this in the days to come, what I will not take up is the vaporizers, breathing circuits, and ventilators, maybe a little bit on checking, and then finally we'll end up with troubleshooting. So we have come a long way from the 1850s, from where anesthetics were with a rag over your mouth till Morton came out with the first inhalers. Then you had a lot of other things, the vaporizers coming in till this particular gentleman, which I don't think I need to even say who is this, Boyle, who first designed something wherein you could regulate the flow, blend the gases, and give it possibly at a desired concentration. And that was the initiation of the anesthetic machine, to say, to today's day and age, when we call it the workstation. And you have so many, and all very sophisticated, all very high-end, making it very, very safe as to the delivery of the anesthesia. But what is in the heart of this workstation or anesthesia machine? It is a device which is for delivering inhaled anesthesia. Mind you, this is the bottom line. That machine is designed to deliver inhaled anesthesia. And what has not changed over the last many decades is that it had, the original Boyle's machine had 5 elements which are still present in the modern machine. And that is the high pressure supply of gases, the pressure gauges on the oxygen cylinders, and the fine adjustment reducing valves, the flowmeters, a metal and glass vaporizer, and the breathing system. You will see that the regulation will touch upon these kind of things as we go ahead. What do today's workstation do? It blends a precision mixture of the respiratory and anesthetic gases, which is through the anesthesia machine and the vaporizers. It dispenses these gases to the patient through the breathing system, has the ability to deliver positive pressure ventilation through the ventilator, and it has also the innate ability to remove waste gases, the scavenger system, and it has also got the integrated system monitors for monitoring respiratory and the machine function. So this is what today's workstation do, and how they perform, what should be the design, what is the minimum safety requirements that you need, are given by the American for testings and materials and the International Standards Organization, and how the anesthesia machine should look like, be like, was given in 2012 by the ASTM and as well as by ISO in 2011, and most modern machines have to adhere by their guidelines. Okay, Jyoti, are you ready with the poll questions? So what we have done is to make it a little bit of interactive, and I know this is a topic which is extremely difficult to deliver as a kind of a solo talk, because I quite enjoy this when I am interacting with people on a workshop, or even it is a kind of an interactive session, because otherwise it can become very, very boring. What everybody, I think we can see around 240 of you there. All you have to do is, like this question has one correct answer. So which of the following is not true about the intermediate pressure system? Now, whichever you think is among these 4 options is not true, which has appeared in your screen on your right hand side, just tick on that. This is just a random thing. Nobody knows who is answering what, so don't feel shy of answering. We need to figure out what you feel like it, and we will address the answers to this audience question right at the very end. And the whole idea is that the take-home messages will be kind of the answers to the poll questions. So which of the following is not true about the intermediate pressure system? Is it the DIS and the quick coupler systems? Is it the oxygen flush valve and the oxygen supply failure alarm? Or in the intermediate system, the pressure in the system is between 75 to 5 psig? Or is it, which is not true, the second stage pressure regulator, is it a part of the intermediate pressure system? So which of these do you think is not a part of the intermediate pressure system? So if you're done, we will close the poll in the file. We begin counting from 5, 4, 3, 2, 1, and 0. And we will go to the next poll question. So the audience, again, this one is which of the following is correct about the pin index safety system? So mark the one you think is correct. Is the pin system for oxygen 1.5, air 2.5, nitrous 3.5, or is it of O2 2.5, air 1.5, nitrous 3.5? Or is it O2 1.5, air 3.5, nitrous 2.5? Or do you think none of these are correct? Which do you think is correct? So just vote on it. I know it is very, very simple. And I have a problem with numbers, which is why I always find it difficult to remember. So which is why this question is here. So please feel free to put in your votes. And once you have put in your votes, we will go to the next poll. We'll get the answers to this right at the end. So if you have the patience to listen to me till the end, you will get the answers to this all. So we'll close it in 5, 4, 3, 2, 1, 0. And you can go to the next poll. Okay, just take a little bit of time on this. The anesthesia machine is connected to the oxygen pipeline system and is also connected to the oxygen E-cylinder. The E-cylinder, which is kept open. In this scenario, which of the following is true? When the central pipeline pressure falls, O2 supply failure alarm will ring and display. Silent leaks in the high pressure system will not deplete the cylinder silently. When the central pipeline pressure falls, the E-cylinder quickly takes over with a subtle indication. In the event of a crossover of pipeline gases, the supply of O2 is then from the cylinder. So which of this 4 do you think is the correct option? Is it when the central pipeline supply falls, the O2 supply failure alarm will ring and display? Silent leaks will not silently deplete the cylinder. When the pipeline pressure falls, the E-cylinder takes over with a subtle indication. In the event of a crossover of pipeline gases, the O2 cylinder takes over. So please put in your vote and we will proceed to the next one in 5, 4, 3, 2, 1, and 0. Okay. The next one. Which of the following is not a safety feature with the central gas pipeline supply? Is it this, the diameter index, safety index, or is it pin safety index, or say systems, or is it the Schrader probes and sockets, or is it the quick coupler system? Not a safety feature. I think this is easy. We will quickly proceed to the next poll in 5, 4, 3, 2, 1, and 0. So the next one, okay, which of the following is true about Flowmeter tubes? In the Flowmeter tubes, which of the following is true? At low flow rates, annular space behaves like a tube. The flow is laminar and viscosity determines the gas flow rate. At high flow rates, the annular space behaves like an orifice. The flow is then turbulent and the gas density predominantly influences flow. About flow meters, they are constant pressure flow meters because decrease in pressure across the float remains constant for all positions in the tube. Or is it all of the above? So about flow meters, at low flow rates, is it a laminar flow, viscosity determining the gas flow? At high flow rate, it behaves like an orifice, annular space. It's a turbulent gas flow and gas density predominantly influences. Is it a constant pressure flow meter, or do you think all the above statements are correct? If you have done your polling, we will proceed to the next and the last one after 05, 04, 03, 02, 01, 00, and we go to the next poll. Okay, now you have a low inspired oxygen alarm that is alarming. The low oxygen supply pressure is not alarming. So the scenario is that the low inspired oxygen concentration is alarming. The oxygen supply pressure is not alarming. In this scenario, which of the statement is true? The possible cause is because of a wrong gas in a cylinder or the pipeline. One of the correct response would be to disconnect the pipeline gas supply from the machine and then open the cylinder and continue. The correct response can be disconnect the patient from the anesthesia machine, ventilate with a rebreathing bag attached to a new oxygen cylinder. Or are all the above statements correct? So if you have a scenario where the inspired oxygen concentration alarm is alarming, but the oxygen supply pressure is not alarming, then which of the following is true? It may be because of a wrong gas in a cylinder or in a pipeline. The correct response could be disconnecting the pipeline gas supply from the anesthesia machine and opening the cylinder and then continuing. The correct response could be disconnect the patient from the anesthesia machine, ventilate with a rebreathing bag and attach to a new oxygen cylinder. Or do you think all of the above are correct responses? So think about this and we'll finish the poll and then we'll proceed to the later part of the deliberation after 5, 4, 3, 2, 1, and 0. I think that's about it about the audience questions. And we will now look to the answers right at the end. So let's start with the anesthesia machine, and let's start with the functional anatomy. And it's essentially, the functional anatomy is nothing but the gas supply systems. If you look at the overview of the gas supply systems, it's all about, again, as I told you, it is the heart is to deliver the gases blended together. So you have the gases which flows from the hospital pipeline or from the cylinder through the adjust it according to the flow control valves, through the flow meters and the flow sensors. It can go through or past the vaporizers into the breathing circuit through a fresh gas, which is called the fresh gas flow into the patient. And the inbuilt, there are the whole, I think we will go through this again and again, is the safety net that is built in to detect that you're not giving low amount of oxygen for the given scenario. So the supply pressure, so that you prevent an hypoxemic gas mixture, regardless of the flows which are being selected by the user. You cannot give a hypoxic mixture. That is the whole idea. There are checks and balances so that the wrong gas does not get into the wrong inlet, whether from the gas tank to the receptacle. And you have an ability to rapidly give 100% oxygen, possibly the oldest safety mechanisms still existing, into the patient's breathing circuit. And there is nowadays recommended, there is an auxiliary system of delivering oxygen to the patient as well. So the functional divisions is classically based upon what is the pressure at various places, the high pressure, intermediate pressure, and the low pressure system. The high pressure systems in the machine is nothing but the cylinder, or the auxiliary gas tanks, where it can be anywhere below 2000 psig, and this section extends from the tanks to the primary high pressure regulators. That's high pressure system. The intermediate pressure system includes the segments exposed to the hospital pipeline pressures, which are coming at from around 50 to 55 psigs, and then it gets downgraded to as low as, in some places, to 13, 15, 10, 5, where the secondary pressure regulators are used. And finally, you have the low pressure section of the gas supplies, which extends from the flow control valves through the flow meters or the flow centers, through the anesthetic vaporizers, and out into the fresh gas supply line. So the pneumatic interior, and this is what possibly we don't get to see when you see the anesthesia machines, this is how from the supply it is measured, mixed, passed to the vaporizers, thus blending and delivered. And the details of this gas supply, you can look at it from schematics, and I will just present to you the two classic schematics that our people kind of allude to. Is the more traditional anesthesia machine without electronic controls, which is essentially that you have something like the flow meters and the flow knobs. So if you look at the left hand side of the screen, this is where the gases are coming in, either through the cylinder or through these central pipelines, and the pressures are coming down from these the high pressure regulators. Then it will go through the secondary pressure regulators, and you will figure out that it goes through the certain other fail-safe mechanisms, like the fail-safe valves or the oxygen failure sensors, and then it goes to the flow meter knobs, past the flow meters, and then the gases kind of blend, goes through the anesthetic vaporizers, and finally to the patient at the patient end through the fresh gas outlet. At the bottom, you'll find that what is recommended, not only do you have one, is that the oxygen flush, which is, as I alluded to, possibly the oldest kind of safety feature which still exists in all machines. And you have the auxiliary oxygen flow meter, through which you can deliver oxygen without switching on the anesthesia machine. And same thing about the oxygen flush valve. This can be done without switching on the anesthesia machine. And if you look at this schematics, you'll find that, yes, which are the areas which are the high pressure system? That is it, the oxygen the cylinders and the high pressure regulators, whether it is oxygen, nitrous, or air. And these red squares are the high pressure systems in that machine, in that schematic diagram, which is the low pressure system. This is in green. This is from the flow control valves, the flowmeters, the vaporizers, up to the to the patient are the low pressure systems, and anything other than this is the intermediate pressure systems, which includes the oxygen pipelines, then through your secondary pressure regulators, check valves, the oxygen sensor failure alarms, the fail-safe valves, and the oxygen flush valve is fed by the intermediate pressure system. And if you look at the contemporary workstations which do not have the flow meters but has the oxygen flow sensors or the electronic flow sensors, it's yet the division is just the same. You'll find that the high pressure system is again the cylinder and the high pressure regulator. The low pressure system comes with the flow control valves, and you can see those are the electronic flow control valves, and up to the fresh gas flow through the vaporizer, and anything other than that is the intermediate pressure system, which is again pipelines, secondary pressure regulators, the auxiliary system, and up the oxygen flush valve that is fed by the intermediate pressure system. So that is about the functional anatomy and the divisions as far as possible with the high pressure. Now I will take you through certain salient things, and what I have tried to do is look at the safety things that are incorporated with it, and not necessarily going into the entirely up to the details of each and every things that are attached to a machine. So we'll start with the gas cylinders. So this is the only possible high pressure section of the anesthesia machine, and classically, if there is a pipeline system in the hospital, this stays inactive as long as the pipelines are functioning. If there is no pipeline system, then it is functioning. But even if you have a pipeline system, it is a must that you have a backup oxygen source as a backup oxygen cylinder, which should take over in the case of a failure of the hospital supply. So that is about the cylinders. It is mounted to the machine by a hanger yoke assembly, which orients and safely supports the cylinder, provides with a gas tight seal, and ensures unidirectional flow of gases. The safety that you cannot attach a wrong cylinder at the wrong place at the hanging yoke assembly is taken care by color coding, labeling, and the pin index safety system, which is known as the PIS. So this is what it has. If you look at it, I think most of you must have by this time been familiar with this. The hanger yoke assembly, which has the index pins, and the corresponding recepting area is in the cylinders. You have the yoke plug, and this is how it hangs to the machine. So the hanger yoke assembly, and this is what the cylinders would look like. And I think by this time it is quite well known that 1.5 is air, 2.5 is oxygen, 3.5 is nitrous for the pin index, the pin system. And as I told you, it has the labels, so it should have a proper label as to what it is supposed to take in. So that is one of the safety things with the hanger yoke assembly. Okay, can this safety feature fail? Yes, it can. Excessive seating, which is essentially jamming of the pins back into the hanger yoke, can make a wrong cylinder be accepted at that position. Bent or broken pins, again, can result in a wrong cylinder getting in at that particular place. And excessive use of washers, if you put it over there, you are basically kind of obviating the pin system, and you allow a cylinder to get in and have a proper gas seal, and that's again a possible cause wherein you can have a wrong cylinder at the inappropriate place. Just a few words about the high pressure regulators and the cylinder check valves. This is a part of the high pressure system. The high pressure regulator reduces the high variable pressure in the in-cylinder to a constant pressure, which is akin to the intermediate pressures, and the check valves will prevent backflow of the machine gas out through an empty yoke or back into an empty cylinder. So you don't want a backward flow of gases into it, and this is where they are located. The ones that are in orange marked are the high pressure regulators. Can you see by the numerics, this is how this 2000 will be brought down to around 45. Same thing with nitrous, 750 will be brought down to around same 45. This is again both, either with Flowmeters or with sensors. They are located at the same place. Now, what is this? How much is the high pressure regulator set at? How much is the pressure at the hospital pipeline? And why have they been made this? If you figure out the high pressure regulators are adjusted to provide a gas to bring it down to 45 psigs, it can be as low as 35 psigs as well. And the normal hospital pipeline pressures, we talked about this initially, is set at 50 to 55 psigs. And why is it done that way? The reason it is done that way, the principle is to see that if it is connected to the pipeline pressure, the central pipeline will serve as the main supply of gas to the machine and not the cylinder, even if the cylinder is being kept open. So this pipeline gas gets the opportunity to supply the oxygen or the gases to the machine, and not the cylinder, even if it is kept open. That is the principle. But this comes at a price. And why I have put up this Robin Cook's medical thriller, which was made into a lovely movie starring Michael Douglas. I think I will not give you the answer right now. You need to go back and figure out why I did this, and possibly the next slide is a clue to this. So the problem with this is, in the case of a suspected hospital pipeline oxygen supply contamination or a pipeline crossover, in which oxygen may be substituted by another gas and the pipeline pressures are maintained, then that gas will continue to be delivered to the anesthesia machine, and it will not be the oxygen from the cylinder. And the only way, and even if you open this oxygen cylinder, oxygen will not get into the anesthesia machine. The only way you can prevent it from happening, if you have suspected that, is by disconnecting the pipeline from the anesthesia machine. So the pipeline to the anesthesia machine has to be disconnected, then the oxygen cylinder opened, and only then you can get in. It is because even if the oxygen cylinder is open, because it is at a lower pressure than the pipeline pressure gas gets in. So that is, and you now why I am referring to Robin Cook's coma, you will figure out. The same question then comes at the beginning. You do the machine check. You open the cylinder 2.5 turns, you see the pressure, and after you do it, should you keep the cylinder open or should you close it? And this is why I always would have loved to have an interactive audience who would have answered this. Anyway, the answer is you keep it closed. The reason you keep it closed is that you don't want the cylinder to get depleted. And there are certain scenarios wherein the cylinder can get depleted, even if there is a proper functioning oxygen pipeline pressures coming in through the central gas supply. Repeated oxygen flushing might deplete it, because it's then taking in a huge flows and the pressures dip in the central pipeline. Oxygen from the cylinder can get in. You have a pneumatically driven ventilator, which is again requiring high flows, that can at times take in oxygen from the cylinder. For certain reasons, if the pipeline supply pressures are fluctuating and it is going down to less than 45 psigs, unknowingly you will get oxygen coming out from the oxygen cylinder and you won't understand. And if there are minor leaks, especially in the high pressure systems, the oxygen kind of leaks silently through those minor leaks without you possibly realizing. So it is ideally that the cylinder post checkup should be closed. The other thing is, if you look at the oxygen pipeline failure alarm, which is nothing but the low oxygen failure alarm. So if the pipeline pressure falls, this is the alarm that starts alarming, isn't it? And imagine a scenario where the central gas line pipeline pressures have fallen, but the oxygen cylinder is kept open. Then the oxygen then comes from the oxygen tank, and this subtle change happens with just a small indicator. Try it tomorrow in your workstation. It will just subtly tell you on the screen that the supply is now not coming from the pipeline but coming from the cylinder. The cylinder icon appears, but there is no alarm as to saying that the pipeline pressures have fallen. The pressures alarm will only sound once the auxiliary tank also has got depleted and there is no pressure in the oxygen system. Which then what you have a pipeline which is there is no pressure. You have an oxygen cylinder which are unknowingly that you did not know has got depleted, and now you don't have oxygen and you don't have the backup cylinder which is full, which is why you would have the cylinder closed, so that if the pipeline pressure falls, there is this audible alarm which we used to call the Ritchie's whistle, and then you go back, open the oxygen cylinder, and see that the oxygen is coming from the cylinder. And meanwhile, whatever, you take necessary steps to ensure that you have more backup cylinders or the gas supplies are taken care of. So that was about cylinders. Let's come to the central gas supply pipelines. If you go at the back end where the central gas pipeline, it could be cryogenic bulk oxygen storage systems, wherein the cylinders, the trucks come on with this liquid oxygen. Smaller systems has this liquid oxygen tanks, which are just like cylinders taken out and brought back, or it can be bank of just oxygen H cylinders. And from that central supply, it comes to your area, to the OR, to the ICU, to whatever area, and it terminates in these patient care areas either through a DIS, diameter index safety system, or a quick coupler system. Within each type, the connectors for oxygen, air, and nitrous oxides are mutually incompatible. That's another safety feature. The DIS relies on matching diameters in the male and female connectors to properly seat and then thread in, but the quick couplers utilizes pins and corresponding slots on the male and female ends, and these are color coded. At the machine end of this gas pipeline, it is always through, and this is the ISO, that it is through, should be through a DIS connector. This is what, again, just go to any text or whatever, you will find how the DIS looks like. That is nut and threading, nut and the receptacle which is threaded in, or the quick couplers with the pins. You also have things like this, and they are nothing but the Schrader probes, which has, again, an index collar with a unique diameter, which only gets into the socket for the same gas type. And you have the non-interchangeable screw threads, which comprises of a nut and probe with a unique profile for each gas. And this is again what it looks like. I think the Schrader probes have something which looks pretty much similar to sometimes like the quick couplers. Coming now to the oxygen flush valve. And this is where it is located. We saw it in the schematic diagrams previously. It is fed by, as I said, by the intermediate pressure. It is one of the oldest features of the safety features of a machine. It has the ability to manually deliver a high flow rate of 100% oxygen. It bypasses the anesthetic vaporizers. As you saw, If you look at it, the anesthetic vaporizers are here in the low pressure. From the intermediate pressure, it bypasses the vaporizers, flow meters, and the flow knobs. And is supplied by the intermediate pressure, remains closed until the operator opens it, is available even when the machine is not turned on, and it has the ability to give as high flows as up to 75 liters per minute. There are certain hazards you need to be aware of. If it's a defective or a damaged valve which can stick in the fully open and it is connected, the circuit is connected to the patient, you can cause barotrauma. And repeated opening or if it is stick to the open position at times, because it will dilute the anesthetic gas, it can result in awareness. And even if you're ventilating with positive pressure ventilation with an electronic ventilators, and you do not have a fresh gas decoupling features, if you have the oxygen flush which is delivering during inspiration, you still run the risk of having a barotrauma. So coming now to oxygen supply failure alarms, this is where you can see where it is here in the schema. So this is where it is going into the machine, and just not the tube that is going towards the flush valve, and it is just before the secondary pressure regulator. So this is where the oxygen failure sensor alarm is positioned. So it is in the circuit of the intermediate pressure, and it will provide an audible as well as far as ASTM and ISO, an audible and visual warning to the clinician if the oxygen supply pressure drops below the manufactured specified minimum. And it can be according to some manufacturers, can be 37, can be 21 PSIGs, can be 40. You should be knowing what it is. I think most of it would be around between 20 to 30. And the feature is you cannot silence it. You can go and press it and silence it until the pressure is restored to the minimum value. So that is one of the essential safety feature of the oxygen supply failure alarms. Along with this failure alarm, there is something like the fail-safe valves, which is nothing but a balanced regulator. And what it essentially does is, in response to a low oxygen pressure, it ensures that the other gases, whether it is nitrous or air, cannot flow beyond a certain rate. This fail-safe valve can be a binary valve, that if it falls below a certain amount, the other gases are automatically turned off, or it could be a proportionating valve. As it goes down, the flow rate of the other gases are also comes down. Are they absolutely fail-safe? Again, it cannot be. Imagine again that scenario. If you have an oxygen gas pipeline which is not filled with oxygen, if you have a oxygen cylinder which has been not filled with oxygen or is contaminated, the pressures are all right. It is all about pressures, mind you. The fail-safe valve, the fail sensors are all about pressures. In such a case, you cannot guarantee that the other gases like nitrous will go down, because the pressures are remaining constant. And the only thing that can save you from delivering a unsafe fresh gas flow is your inspired oxygen concentration, or the FiO2 analyzer, or the oxygen analyzer as you call it, and you yourself, your clinical acumen, figuring out that something is not going on correctly. So none of these sensors are an absolute, so that you are kind of taken out of the equation. The clinician remains very much an integral part of that safety. Second stage pressure regulators, as you see, it is positioned in the intermediate pressure system, and it is essentially to ensure that there is a constant supply instead of an intermittent supply if there is something that is happening to the central gas line pressures especially. And they try to regulate it between 14 to 35 PSIGs. So that was about things that were part of the intermediate. Now let's come to the low pressure system. the first thing that we come up is the Flowmeter or the Flowmeter knob or the Flowmeter assembly. And this again has certain safety features adherent to it. And if you look at it, it has certain serrations, it has certain ridges, and you can see, I think I need not say that it is color coded, it has the label, and the way it functions is by turning and you're letting in this valve and then amount of oxygen that can go in through this. The safety feature, especially I'll talk about oxygen, it is physically distinguishable, it is distinctively fluted, it projects beyond the other control knobs. So the first thing that you reach to would be the oxygen. It is larger in diameter than the others. I talked about color coding, chemical formula which is there, and it is recessed or protected by a shield so that inadvertently when you're moving your hand, you're putting something over there, you cannot change, hopefully cannot change the position of the flow control valves. So then you come to the Flowmeter tube and the float, and the gas essentially passes through this orange space which is called the annular space, and the float is floating and the gas will pass through the annular space. This Flowmeter tube is actually has been if you look by physics, is a variable orifice flow tubes which is narrowest at the bottom and it widens vertically. Gas travels through the space between the float and the float tube, the annular space, and the flow through the annular space can be either laminar or turbulent depending on the gas flow rate. As you will understand, in the lower portion where the gas flow rate is low, the clearance between the head and the float is narrow, so the annular space is essentially tubular. The flow is therefore then laminar, and in a laminar flow, viscosity of the gas determines the flow. Contrast this to the upper portion when you have set higher flows. The channel is orificial because its length is lesser than the width. Then the flow is turbulent, and in a turbulent flow, density is the dominant feature in determining the gas flow. So if you look at this Thorpe tube, the indicator flow is hovering freely in equilibrium, and the upward force from the gas flow is equated by the downward force of the gravity at a given flow rate, and any change in flow rate will either move it up and down. And it's a constant pressure flow meter because any decrease in pressure across the float remains constant for all positions in the tube. And since we realized whether it is laminar or it is a turbulent flow, the viscosity and the density affects the gas flow. So the flow meter is gas specific. You cannot let a nitrous flow in through an oxygen flow meter tube and calibrate it. The tube, the float, and the scale are inseparable because that's how they have been calibrated. Though density and viscosity are influenced by temperature and barometer, but in clinical scenarios, people have figured out that it should not influence the flows. There is again the safety that oxygen goes right down or downstream, and you should not have oxygen upstream, so that if there is a leak or a crack in the flow meter, you are not going to lose oxygen if it is upstream. So you can figure out it should not be as it is on the left hand side, but it should be as it is on the right hand side. That's a safer configuration. And depending upon the manufacturer, you can either have, like Draeger would have nitrous, air, oxygen, or GE or Datex would have air, nitrous, and oxygen. But oxygen is downstream. The problems with flow meters, that dirt or static electricity can cause a float to stick, and sticking of the indicator float is more common in the lower flow range. A damaged float impairs the precise relation between the float and the flow tube, and you will not get actually the flow that you are trying to get. There can be a back pressure from the breathing circuit. Modern machines have abilities to negate it, but the older machines did not, which can cause a float to drop so that it reads less than the actual flow. And if the flow meter is not upright, it is not aligned properly, or then that it will give you an erroneous position, because then you can figure out the physics will not work properly. There are certain hypoxia prevention devices which have been incorporated in this Flowmeter assembly. And the two common ones, one of them is this SORC, which are in the Draeger machines, which is called the sensitive oxygen ratio controller system, or it's in those machines with flow sensors. And what does it have? It essentially has an interconnecting shaft. Into this cylinder, which has the interconnecting shaft, you have a valve which has the nitrous oxide proportionating valve, which you can see on the right hand side with the screws. It is fed by both oxygen and nitrous, and you can see at the outlet there are certain flow resistors, and this flow resistors creates this back pressure, and depending upon the back pressure you can have this interconnecting shaft which can move to the left or to the right. If it moves to the left, you can figure out it will open up the ability for nitrous to flow. If it moves to the right, what it will do is it will close the nitrous oxygen proportionating valve over here, and it will not let nitrous flow. So if you look at it, it's the pneumatic input which is coming from both the oxygen and nitrous oxide flow control valves, and this is coming from back pressure coming from this flow resistors. And let's see what happens when oxygen flows out. There is a back pressure. The back pressure is transmitted to this oxygen chamber diaphragm, and the diaphragm will then move to the right. If the diaphragm moves to the right, you will find out that the nitrous oxide proportionating valve will open, and this will allow nitrous oxide to flow. This is how it works. So if it is turned down too low, what will happen? There is no back pressure, and this shaft, the diaphragm moves to the left, and you can see over here that the nitrous oxide proportionating valve gets closed, and therefore no nitrous can flow even if you have switched it on. It's over here. Okay, the other one is the Link 25 proportionating limit control system, and this is classically in those DTEX machines or the machines with the Flowmeters. I call it like it is like a gear control ratio. So if you are giving a particular gear onto your nitrous, the oxygen gear shift also moves to a certain extent. How does this happen? If you figure out, this is by the mechanical integration of the nitrous oxide and the oxygen flow control valves, and the difference in taper of the needles of the oxygen and nitrous oxide actually does it. Very simple. The nitrous has 15 tooth sprockets, whereas oxygen has 29 tooth sprockets. So if you move nitrous through one rotation, oxygen will automatically rotate through two rotations. Or rather, it will take in one rotation for every two rotations of the nitrous. So there will have to be 1/3 of the gas that has to come from an oxygen source when you are putting in nitrous oxide. So oxygen, the rest of it is, I think, same. It is both are supplied by it is coming at around 30 psigs, and by this link failure system. So if you look at it, there is no way that you can turn nitrous without turning a little amount of oxygen at least. So even if you're giving 2 times, there is oxygen going, and this link 25 of the link proportionating control systems is one of the failure systems. Now there are limitations to it. It may not work, and classically, if after some time the link chain might get faulty. You could again have the problem with the wrong supply of gases, or the leaks downstream, or the dilution of inspired oxygen, especially with very low flash gas flow of oxygen flows, and with something like desflurane, where you require a high fraction concentration of desflurane that can reduce the fractional concentration of oxygen, and you can theoretically have a situation of an hypoxic mixture. These are about Flowmeters and these are the electronic Flowmeters that they look like. And finally, we'll now proceed towards the safety backup. I think this is plain and simple. All of you would know that there, with the anesthesia machine, whatever, whether it's Zeus or a SES, whatever machine you have, you still need your rebreathing, self-inflating rebreathing back always by you, part of the checkup. Along with the oxygen backup cylinder, you should know where there is another oxygen cylinder with ability to give auxiliary oxygen in your operating room area. Suction, I think this would be taken up at some point of time. And coming a few words about scavenging systems. Why scavenge? Because it's to collect and subsequently remove the waste anesthetic gases. You always would give a fresh gas flow of oxygen also at a higher than what the oxygen consumption is by the patient, and as well as anesthetic agents which are not taken up or metabolized, and the operating room can be have higher amount of this. Not only is the anesthetic gases bad for you, but a very high oxygen rich atmosphere may not be ideal whenever you're using very high energy sources of diathermy. And the scavenging systems can be active, which is essentially nothing but you have a actively you're sucking out this scavenged gas, which is through a vacuum source, and a passive, which is you're allowing this little bit of high pressure that is there in the system to go through into a kind of through the air conditioning ducts or through a hose to the outside of the building. It could be open, wherein the atmospheric air is entrained into the waste gas, or it could be closed where the atmospheric air is not entrained. I think this is a schematic diagram which explains the scavenging systems very, very well. So you have the breathing system, you have this collecting system, which is over the APL valves. Then you have a transfer system, and depending upon what system you have, if you have an open, wherein you are entraining the atmospheric air, if you have a closed, it is close to the atmospheric air. And if it is active, you have a vacuum system which comes in, which throws it outside. And if it is passive, you let this pressure take care of the flow of the gases outside. So that's, I think, about scavenging. And these are the examples. This is the schematic diagram of what open active scavenging system looks like, which is possibly there. This is how I think the GE machine scavenging system looks like. And if you have a passive one, which is closed, this is how it will look like. See, the waste gas outlet is not taking in any of the entrant air, and it can go in through a passive supply or through a active scavenging system. Okay, a few things about monitoring. I think about monitoring, you need to monitor the workstation. You need to monitor what the workstation is doing. You also need to monitor on whom the workstation is working, and there should be people who would be responsible for it, and you should be documenting this as well. How often would be based upon you as well as your institution policy. There are methods of detecting leaks and disconnections during the course of anesthesia. There are things in the breathing system sensors, which takes in the threshold pressure alarms, the pressure waveform analysis, and the trend of peak pressures. And this is from which you should be able to figure out whether there is any leak happening. There are workstation volume sensors. See, the workstation, the volume sensors are nothing but essentially they also look at flows. Through an algorithm, they give you the expired tidal volume or etc., but essentially looking at flows. So it can give you the alarms for low minute ventilation or a low tidal volume, or you are not able to deliver a set tidal volume. There is a disparity between the inhaled and exhaled tidal volumes, so what you are setting and what you are getting, and there could be a decreasing trend in that, which should alert you. Exhaled gas analysis again is very important and gives you an early indication. The exhaled carbon dioxide automated monitoring is people who look at it to detect leaks, etc. And any abnormal appearance and the trend of capnography tracing and capnography will be taken up completely separately in this part of this course. The thing to be remembered is that you cannot be relying on the physiological sensors like drop in SpO2, drop in heart rate, drop in blood pressure to figure out any leaks or any things that are happening to the anesthesia machines. By the time it is detected by these physiological sensors, it could be too late and the patient will be decompensating. So you should have the ability to figure out something going wrong or some leak happening or a malfunction much earlier than it is actually reflected on the patient. So the vigilant practitioner is extremely, extremely important. So whether you assess breath sounds, you hear it, or you actually see chest wall excursions, you're paying attention to alarms. And it's not, I think this is something that I keep teaching people when they first come into the OR. The alarms are ringing not for you to just go and switch it off. The alarms, you see what is alarming, why is it alarming, make a diagnosis of why it is alarming, resolve it, and then switch off the alarm. So you observe the workstation and the physiological monitors as well. Things like the ventilator bellows, are they getting filled up completely? Is the adequate tidal volume going? What is your set volume and what is your getting back? Is there any disparity? Are there trends changing? Flow rate requirements, especially if you have an ascending bellow, is it going up at the same flow rate, or are you needing to keep on increasing the flow rate so that the bellows are increasing and decreasing? Look at the bag motion. There are certain, if you're looking at the like the Draeger machines, which gives you the feel of the bag. Is the anesthetic, is this operating room smelling of anesthesia gases, which is again a classic thing that there is a leak somewhere. And ultimately it is boils down to your instinct, and that's your experience, that your vigilance about figuring out if something is not going right. You need to set your alarms properly. See this, you can see the upper thing that you have set your alarm properly. So there is a small dip in the airway pressures, a small leak can be detected if you have set up the airway pressures alarm properly. Unlike if you have set it up at a too low, even if there is a huge leak and or a partial disconnection, it will not alarm because it's not dropping below that. So remember to set the pressures right. You can't have a pressure that is being set to such low stations. And what do you do when you start is the pre-surgery checklist is coffee, and I think this is extremely boring to just speak about. I think this is there in every textbook. This is just a screenshot of the American Society of Anesthesiologists task force on pre-operative checklists, things that you needed to do at the beginning of the day. There are 15 things that you need to do. A few things which your OR technicians can do, but there are, I think all of them need to be supervised by you, whether there is auxiliary oxygen cylinder and the ventilatory settings, the checkout procedures, scavenging systems, etc. You need to, the cylinder pressures, the pipeline pressures, this is at the beginning. There are certain things that you need to do before each and every patient that you will in and attach to the anesthesia machine, the suction, the monitors, alarms. And this is a very common thing. A pediatric patient happens and then an adult patient comes, or the vice versa, adult patient happens and the pediatric patient comes. And you have not changed your alarms settings, you will not detect a partial disconnection. Carbon dioxide absorbents, breathing systems properly placed, your airway equipments, gas flow, documentation, the checkouts have happened or not. And this is again the part of the MS MAIDS checklist. This was made very popular by ASA some few years back. The machine is the M, which starts with the MS MAIDS checklist. The same thing, you cross the Atlantic and come to this side. It is essentially the same. Please go through it and don't ask me to keep on repeating the same thing again and again. There are few things you do in the beginning of the day and things which you do at beginning of each and every surgery. There are few vulnerable areas which on automated checks. Now this modern machine will have their self-testing. We cannot, moment you switch it on, it will go through the self-testing, but there are still certain vulnerable areas wherein maybe there is a possibility of doing the low pressure negative leak test, wherein you can figure out whether a leak is happening in the flow meter assembly or anything downstream over here. Is that essentially a self-inflating kind of rubber pouch which have deflated will get inflated because it will suck in air to the negative pressure over here. So what you do is attach it with a tube to the fresh gas outlet, squeeze it, make it negative, and see if it stays negative or it gets inflated. If it gets inflated, that means there is a leak somewhere in that vulnerable area. And how do you create it? I think this is, again, I put in the slides because I love to show it hands-on in the workshop. So essentially you take this, if you have this old BP sphygmomanometers, you can do it. Since we do not have the sphygmomanometers, what we do it in our hospital is that you have these pressure bags. From the pressure bags, once you discard the pressure bag, you take this back. All you have to do is this end valve has to change directions, and you put it in so that it stays deflated and doesn't get in air from this end. So all the air that can come in is only from this side. So breathing system and the circuitry can be checked. Again, you check in and you see with a minimal flow how much that you are able to maintain a sustained pressure of 30, and it is staying sustained at this 30 pressure centimeter of water, and there is no leak. You can look at the integrity of the inspirator and expiratory valves, especially if you're doing a close, when you have a closed system or the closed circuit, whatever you call it, and you to the bellows. I think this is very difficult to explain with these diagrams. It can be usually you basically squeeze both the things and see that whether only the inspiratory valve is opening, and if you squeeze it from the other side, if you figure out whether only the expiratory valve lid is going on. You have the oxygen concentration monitors, the sensors, the side stream analyzers, the flow sensors, all which we talked about, the breathing circuits, pressure sensors, and finally we will just discuss a few troubleshooting scenarios. Now you have a situation in the operating room where the low oxygen supply pressure is alarming. Now what could be the causes? How will you diagnose what is going wrong, and what should be your response? So if the low oxygen supply pressure, the causes usually are anything to do with the pipelines, inadequate gas line pressures, contamination. It could be a hose malfunction, disconnection, partial disconnection, leak. Cylinder could be empty, wrong cylinders, malfunctions between the compressed gas inlets and the flow meters, a leak, obstruction, or a cross connection. So this could be the causes where the oxygen supply pressure is alarming as low. The diagnosis is you immediately look at the flow meter readings for the gas and find out what is the flow meter reading for the oxygen. Is it oxygen pressures are low? Look at the gauges, both for the pipelines as well as for the cylinders, and figure out whether the oxygen supply pressure is actually low, why it is alarming. So that's how it, and the response would be, the cylinder was closed and you find that the gauge shows that the pipeline pressure is low, open the oxygen cylinder, and till you resolve it, figure out ways of conserving oxygen delivery from the cylinder to the anesthesia machine. If the oxygen flow meter, auxiliary flow meter was on, ensure that it is switched off. Go down to lower fresh gas flows if you can. And if it was with a pneumatically driven ventilators, it will require higher flows. So turn it off, go to manual ventilation, and immediately ask for additional backup oxygen cylinders. So this will be your ideal response. If the low oxygen supply pressure is still a persistent problem, the next thing, that is after you have opened the oxygen cylinder, the next best thing that you can then do is disconnect the patient from the anesthesia machine, initiate positive pressure ventilation with a self-inflating or the ambu bag that you call, with attached oxygen that comes from a fresh oxygen cylinders, and do not use the auxiliary oxygen source if you're not confident about what you are getting from the oxygen cylinder, because the auxiliary oxygen source is also coming from the backup cylinder that is attached to the anesthesia machine. Now, suppose there is another scenario. The low inspired oxygen or the FiO2 analyzer is alarming. The low oxygen supply pressure is not alarming. Now, what could be the cause? How will you diagnose this? And what would be your response to this? The cause is, in this scenario, the supply pressure is showing normal, but the FiO2 analyzer is alarming as low. It is wrong administration due to misconnection anywhere in the gas supply chain, whether it is a wrong gas in the cylinder or a wrong gas in the pipeline or a misconnected hose. So it has got interconnect changed. So the diagnosis should be suspected whenever you are seeing that there is a steady state gas concentration in the breathing circuit, which is dramatically different from what you are seeing as the compressed gas flow meter settings. So you would have expected that the supply, the breathing circuit would have a certain set pressure, but you are seeing that it is different from what you have, whatever flow rates that you are using. But more than that, it rests on your clinical acumen as to immediately figure out that there is something wrong at the back end with the supply that is happening. I think more than this, it is the clinical acumen. The response would be to disconnect the anesthesia machine first from the oxygen pipeline source and open the backup cylinder. If it is resolved, then you know that there was something wrong with the central gas pipeline, wrong gas, or there is a wrong attachment. And you open the backup cylinder. You have to open the backup cylinder after you have detached the central gas line pipeline pressure. And I am repeating this possibly for the 6th time already in the last 1 hour. And that is because the pressure in the cylinder is set at such a rate that it will not flow till the pipelines has been disconnected, but the pipeline pressures are higher, 55 versus 45 or 35. So you have to disconnect the pipeline and then open the oxygen cylinder. And the thing is, it might get resolved, but if you have something that is wrong with the gas in the oxygen cylinder also, then, and your FiO2 analyzer is still alarming, then you know that there is something wrong over there. Then your only thing is disconnect the patient from the anesthesia machine, attach a rebreathing bag, get a fresh cylinder, and then ventilate. So, and the final troubleshooting scenario that I have come to is that you have these 3 things alarming. There is an apnea alarm going on. There is an airway pressure alarm about low pressure that is. There is an airway pressure alarm about low pressure that is going on, and the EtCO2 alarm is also alarming as low EtCO2. What could be the cause, and how will you again diagnose and how will you respond? It is usually a leak. Now, whether it is a leak in the breathing system or a leak somewhere else is what you have to diagnose. So it could be anywhere in the tubings, in this which is or in the gas analyzer sampling lines, or a sensor which is not properly fitted, or a crack somewhere, the APL valve which is cracked, or any disconnection, partial disconnection, which is happening by there is a fall in the breathing airway pressures. Clinically, the first thing that you kind of figure out is how is the movement of the reservoir bag and the ventilator bellows. Am I needing too much of a high flows to ensure that the bellows are going up? The first thing to be ruled out, is there any disconnect or a leak at the airway patient end? Is that, if it is with face mask, very unlikely. laryngeal mask airway, is it leaking over there? Is the endotracheal tube leaking over there? Is there a disconnection over there? Has it come out possibly as well? So first thing, you rule out those things first, and then kind of respond to it. The first response would be to switch to manual ventilation instead of the thing. Fill the breathing circuit with oxygen flush or a high fresh gas flow. High fresh gas flow is something that I prefer. And then look for a breathing circuit disconnection. Is there any, can you see any audible flow through the breathing circuit? One thing that can be possibly done is briefly disconnect the patient from the breathing circuit to perform a circuit leak test. Till that time, the rebreathing bag is attached to the patient and you are ventilating that. And if you can resolve it, fine. If the cause is not immediately found and fixed, discontinue the use of this workstation and initiate positive pressure with a self-inflating manual device, which is in ambu bag, through an auxiliary oxygen cylinder, and continue with the case. I think that is about all that I have for this evening, and we will come to the answers of the questions that we had put in. Which of the following is not true about the intermediate pressure system? I think this was simple. The pressure is never at 75. It is always at least less than 55. So that is not true about the rest of it are correct. The PIS, about I think most people got this. It is O225, air 15, nitrous 35, I think. And it's needless to say that you have to get this. So I think I have deliberately put this up so that it gets into the mind of especially the younger people that the oxygen cylinder should not be kept open. And which of the following is true is that when the central pipeline pressures, the E-cylinder quickly takes over with just a simple subtle indication. And otherwise, you will not know when it has taken over. And there will be no alarm that will audible alarm when the pipeline pressures fall. There is a silent leak. If there is it will empty silently. And for a crossover, you will not able to understand at all. Not a safety feature with the central gas pipeline. It is obviously PIS, that is with the cylinders and the hanger yoke assembly. The rest of them are true for the central gas line pipeline supply system. About flow meter tubes, I think it is, yes, that at low flow rates, it behaves laminar, viscosity determines, high flow rates, it is turbulent, density determines, and it is a constant pressure flow meter. So all of the above statements are true about flow meter tubes. About, again, I think we went through this just a few slides back. The FiO2 analyzer or low inspired oxygen analyzer is alarming. The oxygen supply pressure alarm is not alarming. So which of the following is true? I think all the statements are correct. The wrong gas in the cylinder or pipeline, it can happen. The first response would be to disconnect the pipeline gas supply from the machine, open the cylinder, try to ventilate. Next response, which is again a correct response, would be disconnect the patient from the machine, ventilate with a rebreathing bag attached to a new oxygen cylinder. That is about it. Thank you very much. And I think please get in Dr. Anjan Dotto into the room. Make him live. If it is possible. This is nothing like hearing somebody like Anjan Dotto and about.
Well, actually, so far, am I audible?
Yes, Paulash, you are audible.
Okay. So far, I have got only one question, and I think only he will be able to answer that. So there is one person called Joseph Dana. He has asked me a question long time back that in a Boyle's machine, there is some port which is nearby the oxygen flush. What is this? Then I asked him about the model. He said Boyle MK111S. I can't find this model, but what probably he is mentioning is that there are two port-like things which are below the table, and there are two of them. So do you have any idea about what exactly is this? I have a guess about this. I'm not 100% certain. You need to find it out. It is possibly an oxygen outlet port, not an inlet port, to give a gas supply at a slightly higher pressure to the oxygen-driven ventilators, which are connected separately. I'm not sure. You need to cross-check it.
But you mean to say it is something like the auxiliary oxygen port?
Yeah, which will supply oxygen to the to a driven ventilator.
Okay.
I'm not certain. I'm just taking a guess. It's an old machine. I mean, it's been a long time back since I have used any one of those.
Is Anjunda around? Then I think he's the,
okay.
as you rightly said, he's the best person to.
Yeah, that's what I'm said. Okay. Dr. Muhammad Ghulam Hussain says that can we get the slides? You can actually visit the whole presentation. You will not get the individual slides, but you will in future will give you a link where you will have a recording of this whole lecture, so you can go through this lecture at your own leisure, pause and assimilate things, then go forward. Okay, we have a question from Dr. Preeti Badigar. I hope I got your surname correctly. At what flow laminar flow changes to turbulent flow? I think that is a short question, something about Reynolds number and all.
Yeah.
So there's an equation in your book that you will have to look up, and so a number of factors which determine this thing. Is it possible to give an exact flow at which it will be?
I don't think you'll ever get an exact flow, but it usually would range somewhere, I think, beyond for oxygen it is somewhere beyond 8, I think.
Okay, Dr. Amna Goswami wants to have a word. I
know that there is, I can see Anjunda.
Oh, right.
Namaskar.
Actually, the person who has asked the question is obviously non-Bengali. We have one question that in older Boyle's machines, it's given me a model number of Mark 111S. In that, there are two port-like things which are at the bottom of the table near the oxygen flush valve.
Yes, got it. No problem. That is absolutely a secondary outlet. It is a starter type outlet. It gives out 60 psi oxygen directly from the cylinder, because these machines are made for cylinder only. They bypass the whole thing, and it is a 60 psi outlet, so that you can run the Manley ventilator. It is made for Manley ventilator, which was being placed just at the bottom of the yes. or for neonatal resuscitation, or is a secondary, just is a miniature pipelines. You can say it's a miniature 2-outlet pipeline.
Thank you, Anjanda.
I think I don't think anybody could have answered this with this much conviction. So can you tell us a little bit about the evolution of the Boyle's machine?
I think it will be another class.
I think we do have a few.
We'll have another class on that. Just a few salient things that you would add to whatever has been discussed. Anything salient that you want to bring out? We would love to hear it from you.
I am just focusing to a question number 6. That's the last question. Because I have been witnessing a lot of accidents throughout India. Especially in this city, a very big corporate hospital has lost 2 patients because of crossover of pipeline. And that, incidentally, I went that hospital day before the incident, and I called all the biomates there because most of them biomates are my students. I told them that your theaters doesn't have the FiO2 cell active. Then the answer, sir, the hospital authority, they don't buy FiO2 monitor because the company, the FiO2 cells they supply is a paramagnetic cell, not paramagnetic, is a fuel, is a fuel cell, not is a fuel cell. Fuel cell last only 9 to 11 months, and it is a high cost. They are not purchasing, just it is attached. And because I carry my FiO2 monitor wherever I go, and I check that it is not working and it is giving wrong signal. And incidentally, in one theater in the second floor and one theater in the top floor, 2 patients died of cross connection. Lately, it was discovered and hush up the that case because of not failure of oxygen FiO2 monitor. It is failure of the management part and the anesthetics of a whole scenario. Those who are involved in that and biomates, they just fear of their bosses. They don't want to purchase. That it is happening. And if you go to anywhere in Calcutta, still on my feet, I'm very few, excepting your hospital and few corporate, none of the machine has working FiO2 monitor. Though India is manufacturing FiO2 monitor at the cost of only 18,000, including the cells. It is available freely in the market, and ISA headquarters is advocating that there only one monitor. If you have to purchase, buy it and attach it. It's only 18,000, and that is the only answer of all these accidents. The final safety is the FiO2 monitor.
I think that is exactly why I put in that audience question number 6, so that it gets into the people's mind that the oxygen pipeline pressures can be normal, but you still can be delivering a hypoxic mixture.
Yeah.
I think in that case, the third patient was saved by the promptness of the anesthetist. Otherwise, there would have been a third casualty. The anesthetist promptly disconnected the circuit and ventilate the patient with an ambu bag, connecting with a oxygen cylinder.
The theaters is having active ambu bag. Most of the time, you will find the leaking or melted ambu bags. That is all.
So I think one of the take-home message from what is that
ambu and FiO.
It depends upon what you are working with. You need to be happy and satisfied with what, and you have to be safe.
So, sir, may I add one word about FiO2 monitors? So most FiO2 monitors are at the machine end. So I think 2 FiO2 monitors, which measures the FiO2 just at the time when it is going into the patient, that just proximal to the filter, which is connected to the endotracheal tube, would be more suitable.
No. It should be a standard teaching is that at the outlet of the machine, the FiO2 monitor should be attached at the outlet of the machine.
Yes.
That is
most machines will have it.
Yes. And for corporate buyers, I will always say don't buy a FiO2 monitor with which is having fuel cell. You go for paramagnetic. So, no reckoning expenditure is there. And for younger generation, in the taluk level or in the district level, those who want to do safe practice, buy a FiO monitor on your own. I am telling you, the cost is only 18,000 rupees, and sale price is 1,200 rupees only.
Absolutely. Thank you, Anjanda.
Okay, there is one question from Dr. Devashish Jatwa. He wants to know why in the audience question number 3, the option 2 is not the correct answer.
What was the question? I've forgotten. Is it about the cylinder that is oxygen cylinder, backup cylinder that was open? I think, right?
Can you show that question?
Yeah, I think I'll just go back to the slides.
Go back to the slides. Question number 3.
What? So What was the query?
Why option 2 is not the correct answer?
Because if there is a silent leak, it will silently deplete the thing. It is not true. It will not deplete is not true. It will deplete. Isn't it? It will deplete, so it is not true. Not deplete is not true. Right, Palash?
Yeah, fine. Any more questions?
Dr. Amna,
yeah, she wants to get in, but I cannot let her enter. Can there are 3 entries? Okay. Right now, yes.
Palash, anything else that you need to figure out?
I don't think we have.
You can make an announcement.
Okay. Dr. Shoiwal Naha is asking why the placement of the oxygen flow meter in the system. It's not a very clear question. Probably where it should be placed or where it is placed.
It is always in the low pressure, just before, just proximal to the vaporizers. So that the first blending is between the oxygen, air, and gas, and then the blending with the vaporizer, vaporized gas, then goes to the common fresh gas flow. Palash, I think for the future, for the upcoming sessions.
Okay, I think let me announce about the next week. We will have a program at it's the same day of the week at same point of time at 7. We're going to start, and we'll be talking about breathing systems, and we'll be talking about the gas supply and storage, and a little bit more detail about the scavenging system. The scavenging system has already been touched. So in the meanwhile, we would like to get your feedback regarding what are the problems you faced. I am sure that quite a few of you faced a problem with connectivity issues. So I would request you, most of you, to connect to a wired broadband if possible. Stay close to your modem and use a LAN cable to connect your computer. Use a compatible browser. It would be best with, if you are on an Apple system, to use Safari, on a Windows system to use a Google Chrome, and use a headphone so that the feedback is minimized. You will have to register again for that thing. For every class, you will have to register, and you will receive a personalized link that will be sent to you, through which you will be logged in, just like we did today. I would like to make a couple of more announcements. We have already circulated. This year, it won't possibly, we will not be able to have a physical conference, but we have made a decision so that we will conduct the competitions. So everybody who would like to participate in these competitions, please send in your full article or abstract as suitable to my email address, and the notifications, so their notifications should be repeated. The last date is the last date of this month. If you have any queries, please get back to me, and we'll be happy to help you. Now, Dr. Sujata Ghosh. Hello. I think she has just joined. Yeah, I think we are through to this program. Okay, so thank you, everybody. I guess good night. We'll meet again same day of the week, 7 days from now at 7. Thank you, everybody. And some of you who have wanted for a link, would provide you with the link where you can watch it. Yeah. Okay, thank you, everybody.